I got it. Hey everybody, Andrew here. Surprise appearance in Neuro VMR with Aaron and Hans is the case for us today. Hans, do you want to say hi?
Yes, a brief hi. I'm a medical graduate and I intend to go for the match next year if possible. So I have a case today from a friend who is on a neuro rotation and he presented it to me. And I found it so interesting that I was working it out for the VMR today.
Amazing. Thanks so much for bringing it, Hans. I think we're all set to get started. Let's do it.
Then I'll start with the chief complaint, and that is a 21-year-old female, and she presents with throbbing headaches and loss of sensation with weakness in the left leg. She has loss of sensation in her leg as well.
Okay. Andrew and/or Maria, I know you're multitasking, but if you're at a quiet moment and want to chime in while you can, that's fine too. Or I'll let both of you CP solvers, leaders, and pros decide how you want to discuss and which. Up and Maria disappeared. Okay, you're up, Andrew.
Uh, all right, I'm up. Yeah, disclaimer for the VMR episode. I'm going to introduce a new principle, Aaron. You know how there's a localization times time course. I'm going to say for neurophobia, the more you're away from med school, if you're not in neurology, the stronger your neurophobia is. So I'm just going to put that out there as I'm graduating my medicine residency here. But thankfully, this is a problem that I see in the primary care clinic pretty frequently, which is headaches. So let's just frame it as headaches. So they're primary and secondary headache disorders, the primaries being the ones that we see kind of in the clinic all the time. I've only seen one secondary headache in clinic, which is a whole other story. But yeah, we can divide headache into tension headache, migraine headache, and cluster headache. And, interestingly, the one that can have these kind of transient neuro symptoms along with it is migraine headache. And we do have a patient here who is having that kind of classic description of a migraine headache being the throbbing nature. We don't know if it's unilateral yet. And there's this loss of sensation in the leg. So there's like focality. So, in a transient setting, my understanding is this could be consistent with migraine and something benign. But I think seeing if that persists is going to be probably the most important thing here. So we have an approach to secondary headache if this is something we do have to end up considering, after more history and after our exam. And it's basically an anatomical approach, which is really extensive because it turns out there's a lot of anatomy in the head. So you can start kind of like external to the head and move inward to try and figure out what could be going wrong. So you can consider like ocular disorders like glaucoma, like high pressure inside the eye. You can consider like bone disorders, which we saw on RLR, where they're like bony tumors that can cause pain. You can go next to like the meninges, consider like meningoencephalitis. And then you have everything else inside the brain, like CSF, excess amounts of that, in the form of like hydrocephalus, vasculature, vasculitis, all these sorts of things. So basically, it's very extensive, and I think getting more information in a physical exam can kind of help you tailor that. But I'll pass it off to Aaron. It's hard to make progress without more information here.
Yeah, fantastic. Anything you wanted to throw in, Maria, or multitasking listening for now?
No, I love that framework from Andrew with that separation between primary and secondary, and then the anatomy-based approach. I would just I think migraines are really scary, and as Andrew mentioned, migraines can do a lot of things, but as long as you're seeing any sort of red flag, I think it's important to consider secondary headaches first, and leave primary headaches as sort of a possibility after you've ruled out everything. So loss of sensation and even like loss of like motor function weaknesses during migraines are possible, but definitely want to rule out anything ischemic or demyelinating, for example, in this young female. Right now, I'm not quite sure if the loss of sensation is episodic only during the headaches, or that they have a residual afterwards. So I think that will also be good to clarify with the history.
Brilliant discussion, both of you. I don't have too much to add, maybe just to say similar things to what both Andrew and Maria said, just in how I think about it. So you see multiple ways of framing sort of the approach to the same problem. So yeah, one thing Andrew said and one thing Maria said that I want to sort of put side by side, which I think are important. Maria said that primary headaches are sort of a diagnosis of exclusion because you would not want to miss a secondary headache because it could be a serious underlying cause and or could be a curable cause, whereas the primary headache disorders we don't fully understand, so we're treating them symptomatically. I want to put that side by side with what Andrew said, which is in practice after several years of internal medicine residency, you can only really think of one secondary headache in the outpatient setting. So this is a challenge here in terms of signal to noise clinically, because the majority of, we probably everyone here this morning, all 32 of us has had a headache, and we're here discussing on VMR. It's a very common symptom that has a huge differential diagnosis. And most of the time, as Andrew is telling us in practice, and my experience as a neurologist with an enriched population of headache patients is most of the time they are some type of primary headache disorder, or maybe secondary, but not to some underlying serious cause that we would all hate to miss, like a subarachnoid hemorrhage or a tumor. So there's this sort of fear of what's in the signal, and the, as Andrew said, the epidemiology, that most of the time we end up saying, wow, that was weird, it had this symptom and that, but imaging was normal, and I guess we're going to call it a migraine. My mentor, Marty Samuels, liked to say migraine is the neurologist's best friend, because so many things you can tell the patient, I'm not sure what this was, but you had a little headache with it, and migraine can do so many things. I think you had a migraine. Like, oh, okay, well, that's not too scary. We can deal with that. So this primary, secondary, this is sort of the heart of the schema for headache, with the primary disorders, meaning that they have some cause, but not one we can identify with our workup. Tension headache is an example, migraine, both very common. And then cluster falls under an umbrella of some very rare conditions called trigeminal autonomic cephalalgias, or TACs, TAC in the business. I feel like the step one makes headache, migraine, tension, and cluster sort of these three equal things you could see in real life. I've maybe seen 3 cases of cluster ever. And just for reference, something I've found myself saying a lot recently because it's surprising to me is this is my 10th year out of residency. So I see a lot of patients. I'm a full-time clinician. It's not very common. And the other ones in that group, things probably never heard of, and some of which I've never seen. SUNCT and SUNA, sudden onset unilateral neuralgiform headache with conjunctival, I don't even remember, and trigeminal something. There's paroxysmal hemicrania. So there's so many headache disorders. There's the international classification of headache disorders you can open. It's like the DSM for headache. People got together in groups and made criteria and said, there's primary stabbing headache, and there's nummular headache that's the shape of a coin. These are just things that you see in life, and people wrote about them and they try to treat them. So chances are, most of the time you're seeing a primary headache, probably not in morning reports. So I think that epidemiology Andrew mentioned is key. And so is Maria's point that it's harder to and scarier to think about these secondary headaches because they're fewer, they're rarer, and the stakes are high. And so my framework for the differential diagnosis for the secondary headaches is, as Andrew said, sort of anatomical, but I keep it in 3 broad buckets, which is just of the head, in the head, and systemic. I should say of the head and neck, in the head and neck, and systemic disorders. So by of the head, I mean all the things that are not inside the skull. So as Andrew said, you have eye things, ear things, sinus things, nose things, dental things, jaw things, all can cause headache. Similarly, cervical spine disease, of the head and neck. And then in the head and neck, you have the brain, meninges, blood vessels, ventricles. In the neck, you have the arteries that could become dissected or otherwise. And then systemic diseases, we've all had headache from getting the flu, from the COVID vaccine, from being dehydrated, having a high fever, what have you. So that's sort of a helpful frame for me because it's sort of going to guide some of the questions we have. And so what we're keyed into on the HPI is then how are we going to distinguish primary from secondary? Obviously, if the patient comes in with a headache and is blind in one eye, or a headache and is paralyzed on one side, okay, we're concerned there's an underlying lesion in the brain that's causing both headache and focal symptoms, which may be the case here. However, we have a sort of set of questions, or sort of review of systems for headache, which is looking for the red flags. There's some mnemonic, Snoop, PPPPP, that I can never remember. Basically, these are characteristics of the headache that on the history would start raising your antenna or your red flag for this one's not behaving, in a sort of benign way. And those would really mostly be things that hint at some neurologic process. So is there any focal symptom? Weakness, numbness, visual loss, dizziness, etc. Although you could have all of those with migraine, as both of you said. Are there symptom signs of elevated intracranial pressure? Maria, Andrew, what would be some of those questions you would ask and things that would make you frightened for elevated intracranial pressure?
It'd be like positional headache, worse while lying flat, if I remember correctly. And would blurry vision be part of this as well, or no? I'm just thinking of like the papilledema you could see, but I'm not sure.
Absolutely. Yeah. So there's the high pressure symptoms, what I call brain orthopnea. That's my term just to do a lot of teaching for internists. You lay down, your CSF that had gravity helping it move down the spine is now in equilibrium, brain and spine. If you have normal pressure, your brain's fine with that. If the pressure is elevated, your brain is unhappy with that. So a headache that wakes someone up at night, a headache that's worse in the morning, a headache that's worse when lying down, headaches worse with coughing, sneezing, laughing, Valsalva, all those sorts of things that could raise pressure. Now, if you cough really hard, you can try it, or if you've coughed recently, it does give you a little headache. But if someone finds that, or if you have a headache, a cough will make it worse, that there's really sort of that feature as part of it. And then blurred vision from papilledema, from pressure on the optic nerves, double vision from pressure on the 6 nerves, called the false localizing sign, because it's not a focal lesion, just pressure stretching the 6 nerves. Those could all be elevated ICP sorts of things. And then features of the headache. Is it the worst headache of life, thunderclap headache? Those are sort of sudden subarachnoid hemorrhage types of things. So features of the headache that make you concerned for particular pathophysiology. Features of the patient with cancer and a headache, worry about metastases, HIV and a headache, worry about some type of focal infectious lesion, etc. And then particular kind of illness scripts, older person headache, jaw claudication, visual loss, giant cell arteritis, younger person, recent weight gain, elevated ICP symptoms, pseudotumor cerebri, also called idiopathic intracranial hypertension, etc. So coming back to this case, well, it's morning report, maybe it's migraine, but maybe it's a focal lesion causing headaches and this loss of sensation. So one tiny final clinical point, or final for now, it is said, though there's no perfect rules, that migraine usually causes positive symptoms, meaning there is a presence of a symptom that wasn't there before, and seizure also, whereas stroke, TIA, usually causes negative symptoms, meaning loss. So migraine, very classic, the visual aura, flashing lights that aren't supposed to be there, spreading paresthesias, and stroke, TIA, the patient says, I lost vision in my eye, or I lost feeling in my arm, I was numb. None of these are perfect rules. There are no perfect rules in medicine, and people with migraine can get weak a little bit or a lot in hemiplegic migraine, which is a genetic, I think it's calcium channel or sodium channel or either genetic syndrome. And patients with stroke can actually have secondary migraine. I've seen cases where the patient presents with a migraine, they've never had one before, and the visual aura is persistent and had a little occipital stroke that's somehow triggering migraine. So yeah, I think off the bat, Maria and Andrew, just hearing the chief complaint, primary headache disorder, secondary headache disorder, worry meter low, worry meter high.
Since we're in VMR, probably going to be a secondary headache.
Okay.
We will see what Hans brings us next.
Or a very atypical migraine. Yeah. Or what are you thinking, Maria?
Yeah, I can't get over my morning report bias. So secondary headache and worried a lot.
Yeah, good to know our biases, even our morning report bias. Yeah, there's a focal symptom here. We spent a lot of time talking about the headache, always useful to review. We could spend a lot of time talking about the loss of sensation on one leg, but let's hear the history first and see what direction we're going here. Okay, Hans, tell us a little bit more, please. Thank you.
So the history of present illness, the throbbing headaches with loss of sensation and weakness have been going on for 3 weeks. Sometimes the headaches were accompanied by nausea and photophobia. Of great concern for the patient was the loss of sensation and weakness, which affected her left leg, then her right leg, and upon another occasion, her right arm. This is why the patient decided to come to the ED. On her first ED visit, a CT head was unremarkable. The symptoms disappeared on themselves, and she was discharged with analgesics. 2 days later, after the first ED visit, the headache came back, this time with right leg weakness. The patient was admitted. On the following day, the headache improved. A physical exam and fundoscopy at that time, second visit, were unremarkable. She was discharged with amitriptyline for headache prevention. Then 10 days later, after the second visit to the hospital, the headache returned again, this time with confusion, right arm weakness, and loss of sensation in the same arm. So she had the right arm was weak and there was no sensation in her right arm, and loss of sensation in her face. And I have a review of systems as well for this aliquot, whenever the scribe is ready. In the review of system, the patient reports migraine headaches since her early teens. These headaches occur twice a year and are not as severe as the present episodic headaches. There are no family members with headaches, and she denies fever, a rash, and weight loss.
Okay. Anything of major significance for the past medical medications, anything like that, Hans, or you want to withhold that? That's fine too.
Nothing of significance other than the headaches. The patient reports to be basically healthy. She's on no medications, and she's also not on birth control or any acne medications.
Excellent. Before we get into this, why did Hans astutely mention some medications the patient is not on? Why is birth control a potential interest, and why are acne medications of potential interest to us in this patient?
Birth control could lead to like hypercoagulability. The acne medications, I'm actually not sure.
Maria, soon to be a neurologist.
I'm not quite sure about like the physiology behind it, but like acne medication, something to do with vitamin A metabolism, which is associated with like pseudotumor cerebri. Why? I don't remember why, but especially in like a young female, that is something that we can consider as cause of her headache.
Brilliant.
Without all of the other signals that she has, just headache.
Yeah. So just putting those out there so people are aware of these. Yeah, birth control could lead to a hypercoagulable state, could lead to a venous sinus thrombosis, usually not episodic, usually progressive, and probably after 3 weeks of that would be something more serious. Patient could be moving toward coma or have a hemorrhage and some persistent focal deficit. And then, yeah, acne medicine, particularly retinoid, retin A. Yeah, I don't know either. I don't know if it is known or somebody knows, somehow can cause intracranial hypertension. Pseudotumor cerebri, I use the correct term. When people have pseudotumor for the reason of recent weight gain, we usually call that idiopathic intracranial hypertension. When you say pseudotumor, even if you say to the patient, this is going to sound scary, but it's not pseudotumor, and they hear tumor is what's kind of echoing in their mind. But with vitamin A or tetracyclines in children, it's not idiopathic intracranial hypertension. It is pseudotumor, this phenomenon of for some reason the pressure is high. I don't know what vitamin A has to do with it, but for those of you who play neurotrivia, if you hear a stem of a question about eating polar bear liver, that apparently has a lot of vitamin A, and it's going to be pseudotumor, probably not in real life. Okay, excellent. Just wanted to make sure people knew those little clinical factoids. Okay, what's going on in this history? While you're still with us, Maria, before you get pulled away, do you want to tell us what you're making of this complicated history?
Yeah, of course. So I think initially we were debating if primary, secondary, and as you went over all of the different red flags that makes us think more about secondary, she has a lot of them. So things that are concerning in this case and that would not align with like a primary headache syndrome would be a lot of like the systemic features as nausea. I think she didn't have fever, but also, well, if she would have fever, that would have also been something to worry about. All of like the focal neurological signs, although I can't really say they're focal because they're a little bit scattered. Um, so not just pinpointing to one place, but moving around different extremities. I think that I'm not quite sure what to make of it, but definitely worrisome. And particularly the confusion, I think, makes me even more worried than before. And the fact that I think something that we didn't mention initially, but in people who have migraines, any change of like the characteristics, the intensity, the frequency of their headaches is also a red flag. So even in this case where she is somebody that experiences migraines, these are not the usual ones, so we should be concerned about them. In terms of where I'm heading towards, I think whenever I hear confusion with headache, my head immediately goes to like a meningoencephalitis picture. So for me, it's either headache, fever, or confusion. And if they have two of three, I tend to think about that one first. I think in this young patient, I'll be interested in knowing her risk factors, her HIV status, any other sort of immunosuppression. And then it's good to know that she's not on birth control, but maybe she also has different risk factors for ischemic etiologies. So definitely want to check her heart in case she has something there and that's causing like embolic strokes that's giving us these like patchy and signs in different extremities. Although it's sort of waxing and waning, so I'm not sure. The CT head, I think, was a good like initial test, but definitely want to get more extensive imaging with her, MRI, and then possibly like vascular imaging as well. So regarding your first question, secondary and very, very, very worried.
Okay, I hope everyone was taking notes. You're witnessing the passing of the torch to the next generation of neurology. Maria is just doing such an amazing job analyzing the facts of this case and then kind of what that makes her think about and what we should be thinking about and all the things. Probably one of the key things is to see what we can try to make sense of, but isn't making sense yet. So just absolutely brilliant, nuanced discussion as always, Maria, and we will soon be passing the torch. You can do this. You hardly need me here anymore guiding this discussion. So yeah, this is a confusing presentation. Actually, let me ask you one more question, Maria, but wanted to say that first. Could this still be migraine?
Ooh, that's a good question.
Thank you.
I would say I know that migraine can do a lot of things. I haven't heard of a case with migraine and confusion, although that, well, I think we have to define the confusion. Is she a little sleepy or is she like disoriented? But I don't think I have that on my illness script for migraines, the confusion. So I would say no.
Okay. Yeah, great thoughts as always. Yeah, all you need is the learning environment of your soon-to-be neurology residency, and you will say, man, migraine can do that. That was a migraine. Well, and I'm gonna call it a migraine. I'm not sure what that was. Yeah, you can get confusional migraine. There's a famous video online. People can see it's a newscaster who develops a migraine and just starts developing garbled speech. Looks like they're having a stroke. It was some type of confusional migraine. So yeah, you mentioned so many important things. I'm going to try to I'm not sure I can even remember all of them, let alone make sure we've highlight all of them in bright yellow highlighter because everything was pearls of wisdom. Yeah, this patient has a history of migraine, and the first one you might say, it's probably your migraine. But yeah, change in frequency or pattern of underlying headache disorder, that's a red flag. We didn't mention, and this patient is waving that red flag. Migraines can change. People can start having worse migraines, better migraines. Migraines go away. They forgot they had migraines. Migraines come back. They had an aura before. Now they don't. They didn't have an aura. Now they have them. All these things are possible, and yet diagnosis of exclusion. No blood test that says, oh, you're migraine positive today. Let's let your migraine factor X come down and with this treatment. So what is a little challenging here is there's focality, as Maria said, but it's not the same focality every time, and it's waxing and waning. So do we sort of pull in our transient neurologic event schema here and say, well, migraine is on there, still on the table. Could these be strokes, Maria asked, but they're getting better so quickly. So could they be TIAs, all in different territories? So you mentioned something from the heart. And yet a TIA with a headache, again, anything can do anything, would be a little bit odd. An ischemic stroke with a headache, it happens. We associate that a little more with hemorrhage, headache, and acute or a sudden focal deficit. But why is this 21-year-old having TIAs, strokes, and a different I agree, it's a little stretch. Transient neurologic events. When you're stumped, sometimes you've heard me say, round to the nearest, just simplify. Oop, there are transient neurologic things. Better not miss TIA. It's a stretch here. There's headache. Better not miss seizure. Are these seizures all with negative symptoms? Kind of weird. And as you said, there was a normal head CT, but head CT is good for a big hemorrhage, evolving ischemic stroke after hours, a big mass. But there's lots of stuff we can't see on there. There are lots of little things. Were there little small embolic strokes, as you said, and they were small enough that the patient recovered quickly and now has had a bigger one? That's possible. What else can you not see with CT that might be at play in this case? Guess what I'm thinking. Maria mentioned the meninges. Can't see them on CT. And so if there was meningeal inflammation, as you said, again, brilliant point. We say it's supposed to be fever, headache, altered mental status, neck stiffness. There's a great JAMA Rational Clinical Exam paper. You all know I love these on does my patient have meningitis? And it's like, what is it, 50% have the full triad? It's very humbling. And so something like 96% have at least one of these. Well, that's great. Everyone has a headache. Lots of people are confused. One of those things would not give meningitis. And then just for epidemiologic context, Andrew, you're about to finish residency. How many cases of bacterial meningitis have you seen?
Like 2.
Yeah. Again, step 1, every 5th question, right? Don't miss this. In real life, due to vaccines in our country, bacterial meningitis here in the US, pretty uncommon. I've asked people practicing much longer than me say, yeah, it's a couple of cases. We tap a lot of people saying, I have fever and headache, and just in case, I know they have a UTI, but just in case. But not super common, but again, uncommon things are scary because we're at risk of missing them. Could this be bacterial meningitis over 3 weeks and the patient's alive? That's probably a stretch. As Maria said, is there undiagnosed immunocompromise here? And this patient has, some rare type of meningitis. We don't know where this case is taking place. Some type of TB or fungal meningitis with some small strokes as a result of the vasculitis that occurs because the vessels are in the subarachnoid space where these infectious inflamed meninges are. Meningovascular syphilis. Again, why does she keep having TIAs and not a stroke? It all feels a bit of a stretch. So we can't see the meninges. There's something else we can't see on CT, which it's guess what I'm thinking, but you might be able to see. You asked for this test, Maria. You asked for, so you already thought of it, and I'm not posing the question well. You said with MRI you wanted to see contrast. Is there other stop to the meninges light up? And you wanted vessel imaging. We can't see the vessels, which are one of the things inside the head in my schema that could cause headache. Any episodic vessel, intermittent focal deficit kind of things that could come to mind here? Were you looking for anything in particular with the vessel imaging, Maria, or just in the sense of this is weird, there could be strokes, TIAs, I'm not sure what's going on. As a good future neurologist always says, let's just get an MRI of the brain, and the radiologist say, do you want an MRA with that? And you say, well, now that you mention it, sure, I'd like to see what the arteries are doing. Yeah.
Intermittent vascular, I actually did present a case here of a RCVS once. Now that could most dramatically lead to strokes, which would be pretty bad. But in terms of like intermittent kind of vascular, that's something I'm thinking of. And then Maria already mentioned, or you already mentioned, what do you call it, like embolism from other things as well.
Yeah, RCVS. You want to teach us a little bit about that?
Oh yeah. I should probably yeah, split that up because we don't talk about that too much in the space actually. Yeah, it's called reversible cerebral vasoconstriction syndrome, where for whatever reason the vessels leading into the brain, like the arteries, they kind of clamp down. And if you shoot contrast in, like in an angiogram, you can actually see almost like not beating, but like constrictions like along the vessels, and most dramatically that can lead to like small strokes and true like neurodeficits. It could be primary or secondary. I've seen it secondary to SSRI before, and it completely went away once the SSRI was stopped.
Yeah, fantastic. We're in medical metaphors this morning. So I talked about brain orthopnea. This is sort of, I don't really know what Prinzmetal angina is, but I have a vague memory of it being like vasospasm in the coronary vessels. This is vasospasm in the cerebral vessels, usually triggered SSRIs, marijuana, cough syrup. There's a long list of things that can do this. I saw a case once of a woman who was drinking tons of licorice tea. And I thought, well, licorice has that kidney thing. I don't remember what it is. And we found a case report of the licorice, whatever that ingredient is that does stuff to the kidney. And we thought that was the reason. As Andrew mentioned, you can see this on CTA as beating of the vessels. It's a subtle finding. It's best for those of you who are neurologists, are going to be neurologists. I find it easiest to see in the sagittal plane where you can sort of see the ACAs kind of coursing back instead of in the axial where the vessels are all doing this and you're kind of seeing them just for a little slice. Here you can see the length of the ACAs coming all the way back. And there you can sometimes see this beating. So this can cause hemorrhage in a particular compartment. Might not be what you would think of. Either of you know this as a subtle, slightly gourmet neurology? No. So this can cause convexal subarachnoid hemorrhage, meaning over the convexity, also called sulcal subarachnoid hemorrhage. So as opposed to what we call the star of death, it's not a pleasant way of describing it, but the step one picture of aneurysmal subarachnoid hemorrhage of that bright star and the cisterns. There are other conditions that cause just little spots of bleeding that are just sitting in a sulcus, sulcal or convexal subarachnoid hemorrhage. Trauma is the most common cause where you just burst a little vessel and there's a little bit of blood just kind of rolling around in that sulcus. Cortical vein thrombosis, rare diagnosis sort of in the family of venous sinus thrombosis. And then RCBS, for some reason, sometimes this is how we even remember to think of the diagnosis. Patient has a headache, no trauma, gets a CT, and they say, it's a subarachnoid hemorrhage. Is it an aneurysm? We say, no, it's up at the top. Oh, it's a thunderclap headache, and it's, oh, maybe she has RCBS. Maybe he has RCBS. And then we get the angiogram to confirm that. It's not really clear how you treat this. Some people use verapamil. Some patients get worse with steroids. So sometimes the radiologist will say, beating vessels, is it vasculitis? And the patient gets steroids, gets worse, gets transferred to our hospital. And we say, oh, this is not vasculitis, doesn't present this way. This is RCBS, which is far more common than CNS vasculitis, though I won't get on my soapbox about how rare primary CNS vasculitis is. Okay, could this be RCBS? It does often present in this way that the patient will have a thunderclap headache, maybe get CT, you didn't have a subarachnoid hemorrhage, you're fine, it's migraine, go home, and then comes back. Or in the hospital, this is a really kind of severe episodic thunderclap for the first couple weeks before it cools off after you remove the trigger. So that's a maybe. That's a maybe for this. Yeah, I don't know. Okay, so let's see the exam and see if there is something permanent now, but I agree it's going to be permanent in the sense that not all these transient things, but is there actually an exam finding to help us localize. But I agree with Maria, as soon as you heard the history, you realize this patient is going to need more imaging than a CT. And still not quite sure what we're going to be fine. It's 3 weeks. If it was a focal expanding mass, abscess, something like that, could this be something like that? But why would it be, as Maria said, sort of hopping around to different places? So it sounds more like either something is sending things to different parts of the brain, some type of embolic thing, or in the brain there is vasospasm in different places that has sort of a vascular feel to it. We haven't heard, Hans, is it a thunderclap kind of headache when it comes? Or is it a kind of, oh, she's coming to the hospital, so it must be bad. But did you just tell us that before the history?
No,
Before the exam, sorry.
it's not kind of a thunderclap migraine
It's
or
not.
headache. Mhm.
Yeah. Okay. Yeah. Our CVS it usually is very characteristic, extremely severe. Emergency room. People say hit in the side of the head with a 2x4. Kind of character. So, what was the character of this headache, Hans?
From what I know, it is very severe and throbbing.
Very severe and throbbing. Okay.
So it's more like a migraine headache.
Feels like a migraine headache. Yeah. And so another key point to highlight, migraine is not always a primary headache disorder. Sort of alluded to this. The semiology of migraine can be caused by an underlying lesion that gives a migraine-like headache, or called secondary migraine. Okay, Hans, what was found on the exam? We are all curious.
Okay. Then I'll do quickly the southwest corner, which is past medical history, as mentioned before, none, except for recurrent migraines. The medications, patient has only amitriptyline and analgesics, more or less recently prescribed for her headaches. Family history is unremarkable, nobody with headaches. Social history, she's a university student, but not married, not sexually active. She denies alcohol, tobacco, and recreational drugs. So that's pretty unremarkable.
Okay.
Then the physical exam. The vitals. The vitals are normal, unremarkable. General appearance. The patient is concerned about losing sensation in her face and right arm. And now the neuro exam that we've been waiting for. The mental status, in general, she is confused, but upon further questioning, when she settled down, she was oriented to person, time, place, and situation, so normal orientation. Then cranial nerve exam. All cranial nerves were intact except for CN6. Bilaterally, she showed rectus palsies. Visual acuity was normal. And now the extremities. The right arm strength was 2/5 with loss of sensation notable. The left arm strength was 5/5, sensation normal. Strength in both lower extremities was 5/5, no paralysis there. Sensation in the face was reduced. The patient had no neck stiffness, and she showed no cerebellar signs, and she had a normal gait. A fundoscopy was also done, and the fundoscopy showed bilateral papilledema today. On this third visit to the hospital, she had papilledema in both eyes. Lung and cardiovascular unremarkable. Skin was warm to touch, no rashes, and lower extremities and no edema. And aliquot number 4 will be the lab values.
Okay. Maria, just at the risk of you getting pulled away at any time, do you want to tell us what you're thinking of this exam, and then we'll turn it back to Andrew?
I have time right now. So Andrew, do you want to go first?
Okay. Yeah, a lot of abnormal findings here. Aaron, I'm reflecting on something you said in an RLR episode that was just released pretty recently, like confusion being mistaken for like dysarthria, kind of like language disorders. I'm just thinking like how young this patient is and how much badness would need to happen inside of like the CNS for this patient to like truly be confused. So with everything going on with like bilateral 6 nerve palsies, like if something's happening in the brainstem, this person like just is struggling to like kind of talk. I'm wondering if this person really is having more of like a dysarthria or a language disorder or something like that with everything that's going on. So I'll put a pin in that. And yeah, we just have confirmation that there is a right arm deficit here. But I think the most helpful thing, which we reflected on really early on, is the papilledema being there. And I do remember you saying that you can have the sixth nerve stretched out in the setting of the ICP. So I think we're kind of coming full circle here, and we're kind of worried about there being some sort of form of intracranial hypertension. So I'll pass it off to Maria to talk about that a little bit more.
Awesome.
I love that. No, I was thinking about like the same thing. We do have like a defect in like the right arm, both in motor and sensory. Yeah, motor and sensory. But I'm not quite sure what to make of it because the history has been waxing and waning. So I don't want to like focus on that as much as focusing on the papilledema and the cranial nerve 6. So I think, as Andrew mentioned, there is edema, nothing to make of the cranial nerve 6 because of its long tract, and anything that causes edema will affect it. And then what is causing can the edema explain the right arm motor and sensory function? I'm not sure. I think we should like I don't know. I think and so I want more imaging to sort of figure out if there's anything causing edema that we can see before anchoring on like the idiopathic um, intracranial pressure. And then what to make of the right arm, and I'm not sure. Help, Aaron.
Good. Well, brilliant discussion, both of you, and also always wise to point out what makes sense and what doesn't make sense. That's part of working through these hard cases. I can make sense of all this, and it's a package, and I know what it is. So you both said there is papilledema, therefore the intracranial pressure is elevated. We both noted bilateral cranial nerve 6. Be pretty unlikely to get two symmetrical snake eye lesions in the middle of the dorsal pons and not get the 7th nerve nucleus, which is right near there, or if it's in the fascicle, a part of the nerve that hasn't left the brainstem, somehow you didn't get the corticospinal tract. So if you see an isolated 6 or bilateral 6, you have to wonder if it's affected out in the subarachnoid space. And I don't see how it could be that much longer than 3 or 4 that have to get through the cavernous sash to the orbit, but it's always said and written that it has a long and tortuous course and therefore is susceptible to intracranial pressure. So yeah, we look at what we call burying the sclera. When the patient looks all the way to one side, does the abducting eye get all the way over there? Everyone's looking to the side, but if you do that, you can't see your own eyes in the camera. And so that can be a subtle sign, but here it sounds like it was not that subtle. So we have a package here telling us the pressure is high inside the skull. And we can break that down into 3 possibilities. So what's in the skull? Brain, blood vessels, and the ventricular system. And so 80% of the intracranial contents is brain, 10% is CSF, and 10% is blood, mostly in veins. And so if any of those is taking up more proportion than it needs to, this is not the abdomen where we can just keep growing and growing and growing and stretching our skin over it with a large mass or a pregnancy. The skull is unforgiving. That's the price we pay for protecting our, sorry friends, most important, untransplantable, and most interesting, sorry I said it, organ, is that we have a rigid container so that if it gets hit against something, it doesn't break. But the price of that is if there's even small perturbations in pressure, the curve of pressure, you can get on the steep part of the slope and start getting into trouble. So we're clear about that. And the confusion, Andrew said, we always have to tease apart. Is it actually aphasia? Is it actually amnesia? Is it actually some focal deficit? Is it neglect? Or is it just sort of a general encephalopathy? Here, if we're going along with elevated pressure, could be just an encephalopathy as the patient becomes more somnolent, although they're oriented and they're able to express concern, so not entirely clear there. But they also have right arm weakness. So if you heard right arm weakness and confusion, you might wonder, is there something going on in the left hemisphere and the patient's not speaking properly, as Andrew said. So there's elevated intracranial pressure. there is a focal deficit in the right arm. We know something's going on in the brain. There's something going on the left side of the brain, subcortically or motor and sensory cortex. It's just the arm. So either it's a small lesion in the cortex, or just remember that homunculus, the hand and arm are so big and the face is pretty big, and then the leg is a little smaller. So you can get a monoparesis from a small brain lesion, but a small brain lesion shouldn't be causing elevated intracranial pressure. And this is why Maria was saying some things don't add up. If there's a big brain lesion here causing elevated intracranial pressure, all we got for it is arm weakness, or there's a little lesion causing only arm weakness, then why is it causing intracranial pressure? So we're a little stumped and we need a picture here. And then why didn't they see anything on CT? Again, what could have been missed? A venous sinus thrombosis 3 weeks in, and now the patient has finally had a hemorrhage from the venous back pressure. I suppose that's possible. The focality, intermittent moving around focality, a little tough. I saw flying by in the chat a few times, could this be MS? So I just wanted to address that. Maria or Andrew, we haven't heard either of you say MS. You haven't heard me say it either. Why not? Why did this not feel like MS? Some people in the chat are saying, hey, it's by the definition, isn't it a young, healthy person and disseminated in space and time?
Yeah, Aaron, before this aliquot, I was actually wondering exactly what you just said, disseminate in space and time. But then my question is, how would that cause high ICP in this case, which I don't think that's a thing.
Perfect. Yeah. People with long-standing MS, can they have headache and other things? Yeah, but the lesions in MS are generally small, so they don't typically cause mass effect, and headache would not be a typical symptom. And then it would be pretty uncommon to have, for your first presentation, 3 flares in 3 weeks. Can be very aggressive early presentations. Usually wouldn't have headache. The deficits wouldn't be so transient. Usually they come on over days, hit their nadir over days, and then kind of last for weeks, months, and get better. So everything's kind of happening too fast. But there are cousins of that condition that could maybe behave this way. Guess what I'm thinking, anyone? Something in the family of demyelinating disease that could present a bit more aggressively, acutely, multifocally. Acute.
Aaron, I'm just going to throw out some shotgun answers here, okay? NMO, ADEM, I don't know if any of those could.
Yeah, perfect. Yeah, so you're on the right track. So ADEM, what does that stand for?
Okay, acute disseminated encephalomyelitis something. I don't know the end.
Yeah, you got it. Acute disseminated encephalomyelitis. Yeah, this is more common in kids. I don't see kids, so I don't see it, though I've seen a couple cases in adults. I call it the central nervous system cousin of Guillain-Barré, in the sense that it is an acute demyelinating, but not in the PNS, it's in the CNS. And it's often post-infectious, post-vaccine. Couple weeks later, the kid gets confused and has, some focal deficits, and they have what has been shown pathologically to be demyelination. It's usually, unlike the small ovoid lesions in MS, these big, fluffy, round lesions. They're often enhancing, can be in the brain or spine. It's treated with steroids. And we've learned recently that a lot of these kids actually have a newly described antibody called MOG, M-O-G, which is myelin-associated oligodendrocyte. I think that's myelin oligodendrocyte glycoprotein. Someone fact check me here. MOG, myelin oligodendrocyte glycoprotein. I should know this. We just say MOG in my line of work. And MOGAD is the name of the associated conditions. Myelin oligodendrocyte glycoprotein associated disorders. There's the associated MOG, MOGAD. This is sort of a carve out of MS, carve out of NMO. It can be acute, disseminated encephalo and myelitis. We didn't hear about a preceding infection, but that's something that could be here. Could it have been missed on CT? Maybe. The lesion's usually pretty big. Again, why is stuff coming and going like this? Usually it's sort of an accumulation of deficits over days. That's something else that came to mind. In any case, as Maria has said, as any good neurologist would say from the beginning, I want to see the brain. We know there is a generalized process here causing elevated intracranial pressure. Seems like it's a focal process also, because we have a focal deficit. But why is it only getting the arm? It can't be that big, and yet it's causing elevated intracranial pressure. Yeah, or the patient has multifocal lesions. We said ADEM, or something else. Patient has something going on in the brain and also something going on in the cervical cord, but no, why isn't it getting the legs? Yeah, we have focal and global here, and we need to see a picture to take it further. Did someone put it in the chat? Yes, okay, I finally got it after a few tries. Myelin, oligodendrocyte glycoprotein. Yeah, associated disease called MOGAD. Have not seen a case yet, though I saw cases of ADEM before this antibody was discovered that maybe were MOG, mostly in kids. Can cause optic neuritis, longitudinally extensive transverse myelitis, ADEM, and are recently described. And on Clinical Problem Solvers years ago, my colleague Doug Pett at UCSF presented a case of MOG that presented as, what are they calling it now? Focal cortical encephalitis. This, yeah, once you have a specific biomarker, you find lots of things it can do. And it is called FLAMES, I think. I forget what the acronym stands for. So many acronyms. We love them. Okay. Hans, we want to see a picture. The labs were normal, right?
Yes, you're right. I have imaging and labs for aliquot number 4, and then the CSF exam for the last aliquot. So labs, WBC and chemistry as anticipated, it is unremarkable, normal, and beta HCC, the pregnancy test, negative. Serology, blood. Her blood was checked for Borrelia, toxoplasmosis, syphilis, HIV, Coxiella burnetii, and Bartonella, all of them negative. And some further serology, ANA, ANCA, and rheumatoid factor are negative as well. So next is the imaging then. Imaging, an MRI brain was done with contrast and a venogram. And all of this was negative. There were no lesions found in the brain, and the vessels looked normal. And then an EEG.
Oh,
yes?
sorry.
I can give you the EEG result as well.
It was normal, right?
And
sorry.
The bottom line of the EEG was there are no signs of epileptic activity, though an asynchronous frontotemporal burst of delta waves was seen, more prominent on the left with a slow background, but no signs of epileptic activity, no cortical hyperexcitability. So I'll stop at this point.
Perfect. Yeah, sorry to anticipate the EEG. I think in neurology, sometimes we say, okay, our tests are, I'll say, I'm stumped in this case. We've gotten an MRI brain. We've gotten, like, what are our other tests? We have MRI, CSF, EEG, and EMG. And EMG is not going to help us here. Probably pretty low suspicion for seizures. And I've learned my tendency is that I use EEG less than other people and find the result is often non-specific, but some people find it more helpful, but it can often be ambiguous, as Hans said. And I said, is it normal? He said, well, let me read it to you, because it's hardly ever totally normal in a patient with a brain condition, but what does it actually mean? Hard to say, but I have to admit my bias of if the patient is having an episode in front of you or you're concerned it could be non-convulsive status epilepticus helpful, but in these sort of, we got an MRI and we didn't figure it out, let's get an EEG, I find often not telling us much. But sorry, I also paused you because, wow, the brain MRI was normal. So this is very interesting when it happens, and certainly narrows our differential away from a lot of things. I'm thinking of one diagnosis I thought of earlier and didn't mention because we went in another direction and there was so much fun stuff to talk about. Any diagnoses in your mind, Maria, Andrew, that have this presentation and everything, including the brain MRI, is normal? First, let me ask you this. Were you surprised that the brain MRI was normal?
I'm a little surprised the brain MRI was normal. I don't know what's going on though, Aaron.
Yeah.
I,
Maria? Yeah, sorry, Maria was shaking her head. No, you thought it was going to be normal?
I think it was going to be normal because the history has been so non-focalizing. So I think I'm like as you mentioned before, like we had like the focal right deficit, but that wasn't there before, and there was nothing in the CT that was like big enough that could explain like this level of edema and have some sort of focal deficit. So I was like, what can avoid being seen on a CT scan that can present with edema and focal deficits, but also the history has been so, not consistent. So I was like, I've been anchoring since like 2 aliquots ago. So I was like, hopefully the MRI brain is negative so that it matches what I want to focus on. So I think I was expecting it to be normal just because I was clearly anchoring on it. I am like, is she eating whale liver or whatever you said before?
Got it. Yeah. As I like to say to my residents, and for those of you who don't know, sorry, I don't mean to embarrass you, Maria, but Maria is about to be one of our residents at UCSF, and we need to celebrate that, which is an amazing achievement for UCSF that we recruited Maria, and an amazing achievement for Maria that she matched into our program. So you are hearing me say, and will hear me say, when we work together, okay, you're going to order a test. What do you think you're going to find? Because we order so many tests in medicine and in neurology. Often our internist or ED colleagues have already ordered the test and we see them before we see the patient. In a rare instance where you are about to get the test and don't know what the result is yet, to really ask yourself, what's it going to be? Normal or abnormal? Is this a rule in or a rule out? If it's going to be abnormal, what's it going to look like? Because then when it comes back, you have a match and you say, oh, my clinical reasoning was tweaked in that case. And I thought it would be normal. And even though they said it would come up once at night, they looked so good. I thought it was migraine, but they said when went down. Or you say, it's going to turn out to be abnormal, and then it's normal. Or you think this is going to be normal and it's abnormal. That shock is a big learning opportunity when things don't match. So I guess Andrew and I thought it should be abnormal. There's focality here. There's evolution of this. And Maria thought, yeah, so very interesting. You were correct, Maria. I think, you mentioned that idiopathic intracranial hypertension, you have a focal deficit with that, pretty atypical. And the only kind of imaging negative, severe headache back and forth to the hospital that I can think of is something called handle. This is headache and neurological deficits with a lymphocytic pleocytosis, if I'm not mistaken what it actually stands for. I only saw one case of this, and it was very striking like this, and this is how I learned what this was. Young person like this got off the bus and said he couldn't feel his arm and leg, and he was agitated, he was confused. That was one of my first times as a night senior, and I thought, this guy is sick. If you're supposed to know one thing, are the patients sick? And this guy doesn't look good. He's saying his arm is kind of tingly and he's really agitated. Something's not right. MRI was normal. I got to tap this guy. I remember calling the ICU senior. I said, I'm still new to this night senior thing, making a decision. You would tap this guy, right? He said, oh, yeah, you got to tap this guy. And he had a lymphocytic pleocytosis. And by the morning, he was kind of fine. Like, is this some weird viral thing? But he has no fever. And I presented it morning report, and all the senior people said, oh, it's handle. Like, wait, what? It's what? That's a thing? Yeah, it's a thing. Neurologists have seen it, described it, and given it an acronym. And the patient was fine with no treatment, got discharged from the emergency room, and came back 3 weeks later with the same thing. And I said, oh, well, then what is this? And they said, nope, that's handle. It does it a few times, and then it kind of goes away. It's probably some virus we don't know how to look for. I don't think the ICP should be high in that, though. So, again, another imaging negative thing with elevated ICP, come back to Maria's point, does this patient have meningitis and syphilis, HIV negative, bacterial meningitis for 2 weeks? Patient would not be here to tell the tale. So I would have said handle until we saw that elevated ICP. Okay, Hans, what did you find in this cerebrospinal fluid? You've got us all the three, our 6 hemispheres together cannot sort this one out.
Yes, the CSF and the diagnosis will follow. The CSF exam was done. Opening pressure was 40 centimeter water, so normally 7 to 18. White blood cells, 310 cells per microliter. 95% lymphocytes. Protein is normal with 0.52. Glucose 3.5 normal. And oligoclonal bands negative. Then a PCR was done of the CSF and enterovirus, mumps, HSV 1 and 2, BZV, equovirus, EBV, CMV, JCBK, measles, HHV6, and HHV7 all negative. CSF cytospin, morphologically normal lymphocytes. And I think the diagnosis was already mentioned by Ibrahim and you, Aaron. It's just really amazing people here.
Okay, so I know we're over time, but we're just having too much fun, so we'll just keep going if that's okay, and people can leave as they need. Maria, Andrew, what do you make of this CSF profile?
I know that you just mentioned Handel, but I would not feel comfortable having this presentation, this opening pressure, this white blood cell in CSF. I don't know, I would keep pushing infectious for days until somebody would be like, no, it's okay. Handle is it is. But I'm not sure how how would you go in confirming this diagnosis, honestly.
Yeah. Great point. Watch what Maria did there. She has an illness script for Handel and said, there's some things here that don't fit. We're already talking about a diagnosis with no biomarker, a diagnosis of exclusion. How do you get comfortable with that? Let me ask you this, Maria. We were talking about diagnosis. Would you treat this patient with anything? Obviously, those PCRs were sent and will take a while to come back. You have an elevated opening pressure, high white cell count. Would you put them on anything while you're waiting for these serologies to come back?
Yeah, probably even before we would have been starting with like antibiotics and acyclovir. And I don't know, I would still continue with that. And then even possibly, I know that I've been reading a lot about like metagenomic sequences, and that is also something that I don't understand anything about. Because what happens if you get like a random PCR of something? In this case, I have no idea. I still feel like I need to read more about Handel, and definitely I need to read more about just common viral meningoencephalitis to feel more comfortable saying one or the other.
Yeah, all great points. So what would have happened in real time here? Probably this patient has a severe headache, confused. Before you get any test, you're starting vancomycin, ceftriaxone, if there's immunosuppression of older age, ampicillin, acyclovir. In a lot of patients, I call it nighttime thinking and daytime thinking. The residents say, would you have covered this person, as I overreact? And say, at night, you're busy, you're scared. It's one dose of antibiotics before the morning. Of course, you can call me and we'll talk about it, but do it. And in the daytime, in the light of day, lots of people are thinking about the case and say, I don't think it's that, but you only saw the patient for minutes in the first hours of their disease and you were worried, unlikely to cause harm. Now, sometimes it so happens that then all these things are on and the patient looks better and you're scared to take them off and you're really going to treat them for 3 weeks. Andrew is smiling, saying, I've seen this episode before. And then you're waiting for the CSF profile. If it's totally normal, that could be very early encephalitis, but probably not. If it's this abnormal, as Maria said, those PCRs are going to take days to come back. Probably keeping everything on here. A normal glucose and normal protein, they might say it's probably not bacterial, but as you said, that's a lot of cells. I would be careful. Elevated opening pressure and Handel, I don't know, maybe Hans will teach us. You are reminding me that I saw one case that was classic pseudotumor, very classic. It was a step 1 question presentation. Got a lumbar puncture to drain the fluid and the patient was ready for discharge. And the resident told me, the patient's got like 150 cells. I said, no, wrong patient, wrong CSF. Went back to look at the picture. She looks totally fine. You can't get cells in pseudotumor. You shouldn't have. So I fixed it. I'm like, I know the answer to this, but just confirm. You should never get cells in pseudotumor. He said, your patient does not have pseudotumor. I said, no, she does. And she has cells. And I wondered in that case, does she have pseudotumor and Handel? So did you find, Hans? I've only seen this one case of Handel. There's not much literature I've read, probably what there is, but it's been a long time. Can you get an elevated opening pressure in Handel? Did you learn that in this case, or does this patient have 2 things?
Handel has an elevated opening pressure, and I think the abbreviation of this one is headache and neurological deficits with CSF lymphocytosis, and occasionally in some patients raised intracranial pressure. And that was the reason for her fundoscopy finding the last time. At the very beginning, she didn't have the elevated opening pressure in all likelihood because the fundoscopy was normal, but eventually it developed into that direction. But interestingly, this condition is benign, and there are other conditions that I learned about, and I think Kirtan sent us a paper of immune-mediated brain, eye, and ear conditions, of which Handle probably belongs as well as the most benign. And then the more serious one are Hogan and syndrome, as well as Susak syndrome and a few others that are extremely rare, but of which probably we should at least know in the background of our mind that if a patient comes in with neurological deficits, especially if they are migrating, and it's in our case, that we are aware of them, because in Susak syndrome, it's the eye which is mostly affected and can cause blindness. In Cogan, it's the vestibular apparatus and the ear, which is mainly affected. And all of them are immune related, and all of them have serious outcomes if not found early enough, except for Handel. This one goes away on its own.
Did this patient get better on their own to confirm the
Yes.
diagnosis? Yeah.
I have a hospital course. He stayed for a few days, I think 10 days altogether. And the opening pressure went down. And after 3 months, they did another tab, and her opening pressure was, I think, 20 centimeters, almost normal. The white cells was 7, and the protein was 0.16. It's always been low. So the white cells went down to normal, and the pressure went down.
Wow.
And it all on its own. So it's that was a bit amazing for me as well.
Yeah. Great case, Hans. Very nicely presented, and thanks for bringing it to us. Yeah, this intuition at the beginning that there was a diagnosis of exclusion here from Andrew and Maria, that something seemed not right here, and yet it was hard to tell what was not right about it because the patient kept surprising us. They had deficits, they went away, elevated ICP and a focal finding, and then a normal MRI. So you got to keep pushing. And as Maria said, in real time, we would have gotten that CSF profile and said, whoa, every infection is still on the table. And then maybe as the dust settles and you see they're kind of getting better too quickly for maybe things, and PCRs are coming back normal. Oh, could this be Handle? Again, hold on before we call it this thing. It's just a name for a phenomenon. It's not a disease we understand. Let's make sure everything comes back. So lots of great stuff in this case. I see lots of amazing teaching points from Parisa that have kept getting smaller and smaller the more we talk about, which I love. I think since we're over, we'll save those for the website. But thank you, Hans, for bringing this case. We learned a lot. We had a fun discussion. Maria and Andrew, amazing discussion, not just about the facts in front of us, but how to ask the questions of what makes sense, what doesn't. Can we squeeze this into a schema we know? What is a good fit and what doesn't fit? Invoking schemas for adjacent or around to the nearest things to try to make progress, and staying true to treating concerning things while we wait for diagnoses of exclusion to have everything else excluded. Excellent. Well, thank you very much, everyone. That was a blast. We will podcast this one for sure. And I think actually see you sooner than usual. Kirtan's going to present us a case on a Saturday. So hopefully we'll get to not this, I don't know, some Saturday. Thank you, everyone. Have a wonderful day.